Today's topic is COPD or chronic obstructive pulmonary disease. As the name suggests, there is obstruction or a limitation to the airflow. And this is not fully reversible. The symptoms are persistent and keep getting progressive. So COPD has two main components, that is chronic bronchitis and emphysema. Chronic bronchitis is characterized by productive cough of 3-month duration in the past 2 years, and emphysema is characterized by distension of the alveoli, hence there will be hyperinflation, so there will be barrel-shaped chest. So coming to the risk factors, mainly it is smoking and environmental exposure. It can be air pollution, or it can be the cooking fuel, or it can be the occupational exposure like coal, dust. But it is observed that not all smokers develop COPD, so there is a genetic role to play as well. So the risk factors include mainly smoking and genetic susceptibility, and some other things such as low birth weight or any infections.
Now let's talk about the pathophysiology of COPD. So the certain triggers like cigarette smoke and genetic susceptibility together activate certain effector cells like macrophages, neutrophils, epithelial cells and lymphocytes. These release certain key molecules which results in pathobiological result like extracellular matrix destruction, chronic inflammation, cell death and ineffective repair.
Now the symptoms that the patient will come with are cough, sputum production and dyspnea. You have to make sure to grade the dyspnea according to the MMRC scale, and then once the patient starts talking to you itself, you can notice a few signs like the odor of the smoke or staining of his fingernails, the cigarette staining, and labored breathing. Other things you might be able to observe is that the patient is trying to sit in a tripod position where it's easier for him to breathe, and there is a thing called Hoover's sign where there's a paradoxical shrinking of the lower chest during inspiration. See, normally during inspiration the lower part of the chest will expand, but in COPD patients you can see there's a shrinkage. Apart from that, during auscultation you might be able to hear reduced breath sounds because there is not enough air entry, and sometimes there might be crackles. There is prolonged expiration and there is a wheeze during expiration. So to summarize, symptoms are cough, sputum and dyspnea. Then the signs that you observe are labored breathing, sitting in the tripod position, the smoke smell, the stained fingernails, Hoover's sign and reduced breath sounds, along with prolonged expiration and an expiratory wheeze. Now, an important thing to remember is that COPD does not have clubbing. If there is clubbing of the fingernails, you have to go ahead and find out the cause, other causes that could be something like lung cancer. So for diagnosis, you can do spirometry, and the results of the spirometry can be classified as mild, moderate, severe or very severe based on Gold's criteria. Apart from this, you can do chest x-ray, and ABG will determine whether the patient needs oxygen therapy.
In Gold's criteria, in the mild stage there is 80% of the predicted FEV1, in moderate stage there is 50 to 80%, in severe stage there is 30 to 50%, and in very severe stage there is less than 30% of the predicted FEV1.
Coming to the management, the first and foremost thing is to advise the patient to actively stop smoking. None of the pharmacotherapy can work if the patient continues to smoke. So first, ask the patient to stop smoking and then give them the influenza vaccination. Once that is done, based on mild, moderate, severe or very severe, we can think about the management. So mild stages, short-acting bronchodilator will work. For moderate stage, long-acting bronchodilator plus physical therapy or pulmonary rehabilitation is necessary. In severe stages, the long-acting bronchodilator plus inhaled glucocorticoids. Now, inhaled glucocorticoids will come with a risk of developing pneumonia or any other infection, but there are advantages that it will help to relieve the symptoms a lot. Finally, in very severe stages, you have to go for oxygen therapy and surgical intervention like lung volume reduction surgery or vulvectomy, or sometimes even transplant in very severe cases. Now there is something called COPD exacerbation, which is when the symptoms will worsen beyond the normal day-to-day variation and the patient will require a change in medication. So for this diagnosis, you can either go with chest X-ray or ECG. ECG only to rule out if any other cardiac symptom is causing this exacerbation. And you can go with ABG, that is arterial blood gas analysis. For treatment of COPD exacerbation, first and foremost thing is to give the patient oxygen. Obviously, he's in a lot of distress, so relieve his symptoms first by giving him oxygen therapy. Then short-acting beta agonists with anticholinergic. Then systemic steroids. But you have to remember this is only for COPD exacerbation and not in the normal cases of COPD, because it can come with the risk of a lot of infections. Then if you suspect infection, if there is purulent sputum, then start with antibiotics. Finally, if there is a need, you have to use ventilation. It could be non-invasive like positive pressure ventilation, or it could be invasive ventilation. So this concludes the topic of COPD for this week. If you have any feedback, please do write it down in the comments below, and we will see you next week with a new video.